Welcome to the Hospital Medicine Unplugged podcast. Today we're undertaking a really critical deep dive. We're focusing on something that, well, it immediately dictates acuity and mortality on the hospital wards. The evidence-based management of acute hepatitis in hospitalized patients.
Exactly. It's one of those diagnoses where rapid differentiation and timely intervention can make all the difference. It often determines whether a patient needs critical care right away or even an urgent transplant referral.
Absolutely. And when we say acute hepatitis in this context, what exactly are we defining for our listeners?
Right. So we're talking about rapid onset hepatocellular injury. Clinically, it typically presents as a triad. You see marked jaundice, significantly elevated aminotransferases, often, in the thousands, and a variable degree of coagulopathy, usually reflected by the INR.
And the urgency comes from?
The urgency is really rooted in that narrow window before these patients can potentially deteriorate into acute liver failure, or ALF. That's a state of profound hepatic synthetic dysfunction. And if that happens, it almost inevitably leads to multi-organ failure, cerebral edema, and unfortunately often death.
That really underscores the stakes. And looking at the causes, the epidemiological landscape seems to have shifted, hasn't it? Making this even more relevant for hospitalists today.
It really has. While, of course, viral hepatitis remains a huge issue globally, here in developed countries, alcohol-associated hepatitis, AH, has emerged as the most common cause of severe acute hepatitis that actually requires hospital admission.
And we've seen reports suggesting the post-COVID-19 pandemic period has impacted this.
Yes, there's definitely been a noticeable surge. It seems to have exacerbated the issue, presenting us with, frankly, higher volumes of complex, profoundly ill patients, often with underlying alcohol use disorder.
That surge in AH is particularly worrying. Why is AH often considered so severe compared to other causes?
Well, AH often represents the most inflammatory and potentially the most rapidly lethal form of acute hepatitis we manage, perhaps outside of, say, massive acetaminophen toxicity. The inflammatory response can be overwhelming. But that said, we absolutely must maintain vigilance for the viral causes too.
Right.
Hepatitis A, C, and most acute hepatitis C cases are, thankfully, typically self-limited. But hepatitis B HBV remains a critical factor, especially regarding mortality risk.
How so?
Acute HBV, particularly if it occurs in vulnerable populations or those with certain risk factors, carries a really devastating prognosis if it progresses to ALF. The data consistently show that up to 75% of patients who develop HBV-associated ALF will either die or require an urgent liver transplant. That's a sobering statistic.
A 75% mortality or transplant need. That's huge. And with HBV, we can't ignore co-infection, can we?
You absolutely cannot. We have to immediately think about hepatitis D virus, HDV. HDV is defective, meaning it needs the hepatitis B surface antigen, HBsAg, to replicate. When it's present as a co-infection or a superinfection in a chronic carrier, it fundamentally accelerates and worsens the liver injury. It dramatically increases the risk of fulminant liver failure.
So the initial workup needs to integrate that risk from the very beginning.
Absolutely. Our task right at the start is really twofold. First, rapid identification of the likely etiology. Second, and this is crucial, differentiating between de novo acute liver failure, ALF, which usually happens in someone with a previously healthy liver, versus acute on chronic liver failure, or ACLF.
ACLF. Can you elaborate on that distinction?
Sure. ACLF is where an acute insult like severe AH or maybe an HBV reactivation or even sepsis is superimposed on pre-existing and sometimes previously undiagnosed cirrhosis.
And why is that distinction so critical clinically?
It's critical because ACLF patients follow distinct pathological pathways. They often have a much more pronounced systemic inflammatory response, and their mortality prediction models are different. Their physiological reserve is just much lower.
That ALF versus ACLF distinction is definitely a point where trainees sometimes get confused. Could we just clarify the core definitions again?
Of course. Pure ALF is generally defined by severe acute liver injury accompanied by hepatic encephalopathy, so altered mental status and coagulopathy, usually an INR of 1.5 or more. This all develops within about 26 weeks of jaundice onset, typically in someone with no known prior liver disease.
Okay, and ACLF?
ACLF, by contrast, is an acute decompensation specifically of cirrhosis. It's characterized by really high levels of systemic inflammation, often meeting SIRS criteria, leading to organ failures, frequently the kidneys or brain first, and it carries a very high short-term mortality rate. While managing the organ failures might overlap somewhat, the underlying physiology and, importantly, the utility of specific prognostic scores we use differ quite a bit. We'll get into those scores later.
That clarity really helps frame the differential diagnosis. So for the hospitalist seeing this patient initially, what are the main causes we absolutely need to consider right away?
Yeah, you can think of maybe 3 big buckets. The giants are alcohol-associated hepatitis, again, often the highest acuity in terms of non-viral inflammation. Then there's viral hepatitis, A through E. And third, drug-induced liver injury, or DILI.
And within DILI, there's one we can't miss.
Acetaminophen toxicity. That's the most crucial DILI to recognize immediately because the antidote, N-acetylcysteine, is so time-sensitive. Delay really impacts outcome.
Beyond those big 3, we need to keep our minds open.
Right.
Less common causes.
Certainly. Autoimmune hepatitis is always on the differential. It often requires steroid management, somewhat similar to severe AH actually, but it has distinct diagnostic markers we need to look for. And, we've also seen those reports, mostly in kids so far, linking adenovirus to acute hepatitis of unknown origin. It's just a reminder that the differential has to stay flexible, especially if the standard viral serologies and toxicology screens come back negative.
Okay, so let's talk presentation. Are there core clinical features that are pretty much shared across these different etiologies?
Yes, many are shared. Profound fatigue is common, anorexia, nausea, sometimes vomiting, dark urine, the classic tea-colored urine, and of course the central feature is jaundice, the yellowing of the skin and eyes.
But there can be nuances, like with viral hepatitis.
Right. Viral hepatitis, especially A and B, often starts with a nonspecific prodrome. Patients might feel like they have the flu, fever, muscle aches, malaise for several days before the jaundice becomes visible. That prodromal phase is quite characteristic.
And the physical exam, what are we looking for there beyond just jaundice?
The exam gives us essential clues, particularly about severity. We'll check for hepatomegaly, liver tenderness. But the really crucial findings are those suggesting more advanced injury or underlying portal hypertension. Finding a site ease that's fluid in the abdomen or peripheral edema, significant muscle wasting, those signs immediately push you towards thinking about either ACLF or very severe AH.
That leads perfectly into the etiology-specific nuances. You mentioned AH often presents dramatically. Can you describe that typical severe AH picture?
It really can be explosive. Patients with severe AH often present with not just profound jaundice and maybe already established ascites, but they're frequently hypercatabolic, severely malnourished. And critically, they often meet criteria for the systemic inflammatory response syndrome, or SIRS.
SIRS, that's fever or hypothermia, tachycardia, tachypnea, abnormal white count. Why is recognizing SIRS so important in AH?
Recognizing SIRS is a huge red flag. It's not just a marker of inflammation, it signals an imminent, very high risk of major complications, specifically bacterial infections and acute kidney injury, AKI. And frankly, those 2 complications are the primary drivers of short-term mortality in severe AH.
That sounds quite different from a typical acute viral presentation.
It usually is, yes. Acute viral hepatitis typically follows a more, let's say, measured progression. You get the prodrome, then the transaminases shoot up, followed by the bilirubin rising. While they certainly can progress to ALF, the initial picture is generally less marked by that profound systemic inflammation and the underlying cachexia you often see in severe AH. It really makes the history of recent alcohol consumption a critical pivot point in that initial assessment.
Okay, let's pivot then to the diagnostic evaluation. The workup needs to be systematic and, importantly, rapid. What's the goal here?
The goal is twofold within the first few hours, ideally. Determine the likely cause, establish their baseline liver synthetic function, and assess the severity.
What are the absolute essential initial labs?
The initial panel is fairly standard, but absolutely vital. A complete blood count, CBC, your liver function tests, ALT, AST, total and direct bilirubin, and crucially, the coagulation profile, specifically the INR or prothrombin time. PT.
Why is the INR so critical early on?
The INR is a direct reflection of the liver's synthetic function, its ability to make clotting factors. Its elevation is a core criterion in defining acute liver failure, and honestly, it often supersedes the transaminase levels in terms of prognostic importance, especially as things evolve.
Got it. And then viral serologies, you mentioned universal screening.
Yes, this needs to be universal for anyone presenting with this picture. That means checking HAV IgM for acute hepatitis A, HBsAg, and anti-HBc IgM for acute hepatitis B. The IgM helps differentiate acute from chronic infection. Anti-HCV for hepatitis C antibody. And if that's positive, you must get an HV RNA level to confirm active infection.
What about hepatitis E? Is that still considered only for travelers?
That's a critical update. The guidelines now stress universal screening for hepatitis C virus, both HEV IgM and HEV RNA. We absolutely should not rely solely on travel history anymore. HEV is increasingly recognized as an endemic cause of acute hepatitis, especially in immunocompromised individuals here, and it can progress to severe disease or even chronic infection in some cases. So yes, test your HEV.
And given the HBV-HDV link,
if you confirm acute or chronic HBsAg positive, testing for hepatitis D markers, usually anti-HBc, is mandatory, especially if the presentation is severe.
okay, beyond that universal viral panel, what targeted tests help narrow things down?
Well, number one is getting that acetaminophen level quickly, ideally within 4 hours of arrival if there's any possibility of overdose. And then a really meticulous medication history. That includes prescriptions, over-the-counter, supplements, herbals, everything. DILI is often a diagnosis of exclusion and requires detective work.
What if the picture is still unclear after those initial steps?
If things are still murky, or if there's a clinical suspicion for autoimmune hepatitis, maybe other autoimmune features, or a certain pattern of LFTs, then you'd order the specific markers. ANA, anti-nuclear antibody, SMA, anti-smooth muscle antibody, and serum IgG levels. And we shouldn't forget about Wilson disease, though it's rare. In any patient under 40 presenting with unexplained ALF, or perhaps with associated neurological signs, measuring serum ceruloplasmin is essential. It's treatable.
Let's talk imaging. Is ultrasound always necessary?
An abdominal ultrasound is essentially mandatory, yes. Its primary role up front isn't necessarily to assess the liver parenchyma in detail, although it can show fatty changes or nodularity. The key is to unequivocally rule out biliary obstruction, like gallstones stuck in the common bile duct or a mass compressing the ducts. You have to exclude an obstructive cause of jaundice before committing the patient down a purely hepatocellular management path.
Makes sense. When would you need more advanced imaging, like CT or MRCP?
You'd only move to CT or MRCP if the ultrasound is suggestive of something specific, like a dilated duct needing better definition, or maybe a suspected mass. Or if you're concerned about vascular abnormalities like Budd-Chiari syndrome thrombosis of the hepatic veins, then CT or MRI with contrast would be indicated.
Liver biopsy. When does that come into play?
Liver biopsy is really reserved for specific situations. It's invasive, and it carries a significant bleeding risk in these patients who are often coagulopathic. So we typically reserve it for cases where the diagnosis remains unclear after extensive non-invasive workup, maybe suspected DILI where confirmation is needed, confirm an autoimmune hepatitis if serologies are equivocal, or if we suspect some kind of infiltrative disease that isn't showing up well on imaging.
Okay, so once we've hopefully pinned down an etiology, or at least narrowed it considerably, the next critical step is risk stratification. Identifying who's really sick.
Exactly. Risk stratification is the absolute backbone of management from this point forward. We need to identify, often within the first 24 hours, who is at high risk for deterioration and might need transfer to a higher level of care, like an ICU, or who needs immediate consultation with transplant hepatology services.
Are there general predictors of a poor outcome, regardless of the specific cause?
Yes, there are several consistent predictors. Worsening grade of hepatic encephalopathy is a major one. The presence of an active infection is another huge driver of mortality. Rapidly rising serum bilirubin and creatinine are bad signs. And persistently elevated INR and white blood cell count also point towards a poor prognosis. And as we mentioned with AH, the presence of SIRS, that systemic inflammatory response, regardless of the underlying etiology, is probably the single greatest predictor of impending multi-organ failure and death.
Now, for alcohol-associated hepatitis specifically, you mentioned treatment decisions depend on severity. How do we quantify that severity using scoring systems?
Right. For AH, where therapies like corticosteroids carry risks, these scores are indispensable for guiding treatment initiation. The classic one is the Maddrey discriminant function, or MDF. A score of 32 or greater traditionally defines severe AH and is the threshold often used to consider starting steroids.
Okay, the Maddrey score, what else do we use?
In modern practice, the MELD score, that's the model for end-stage liver disease score, is very commonly used and is actually quite good at predicting 90-day mortality in AH patients as well. A MELD score over 20 generally signals a high-risk group needing aggressive management and close monitoring. There are others too, like the ABIC score and the Glasgow alcoholic hepatitis score, which incorporate slightly different variables like age, white count, BUN, but they generally identify the same cohort of high-risk patients.
Can we just briefly touch on what goes into those scores?
Yeah.
MELD uses bilirubin, creatinine, and INR, right?
Correct. MELD uses bilirubin, creatinine, and INR lab values reflecting liver function and kidney function. The Maddrey score, as you mentioned, uses the prothrombin time difference from control and the total bilirubin level. It's simpler but specifically validated for AH severity.
It sounds like these scores, Maddrey, MELD, are good at identifying who is likely to do poorly at presentation. But how do we track response to treatment?
That's a perfect segue. Those scores are largely static. They give you a snapshot at admission. For dynamically assessing response to therapy in AH, specifically response to corticosteroids, the Lille score is essential.
The Lille score, tell us about that.
The Lille score is probably the most clinically actionable prognostic tool we have in AH management. It's calculated specifically on day 7 of corticosteroid treatment. It incorporates several variables: age, albumin, the bilirubin level at baseline, the bilirubin level on day 7, and the presence of renal insufficiency, creatinine.
And what does the Lille score tell us?
It essentially predicts the probability of survival based on the early biochemical response, primarily the change in bilirubin. If the score indicates the patient is a non-responder, meaning their bilirubin hasn't dropped sufficiently by day 7, then the evidence is very clear. Corticosteroids must be stopped.
Why stop them so definitively?
Because continuing steroids in someone who isn't responding biochemically provides no survival benefit, but it significantly increases their already high risk of serious bacterial and fungal infections. It becomes all risk and no benefit. So the Lille score provides a crucial evidence-based decision point at day 7.
That's very clear. Now, shifting gears slightly to the ACLF population, those with acute decompensation on underlying cirrhosis. You mentioned standard scores like MELD might not be enough.
That's a really important point. For patients with ACLF, whether it's triggered by HBV reactivation, alcohol, infection, or something else, the standard MELD score often underestimates their very high short-term mortality risk.
So what scores are better for ACLF?
We turn to specific ACLF models. The main ones used are the COSH ACLF score and the CLIFC ACLF score. These are superior in this population because they more heavily weight the degree of systemic inflammation, often using the white blood cell count or neutrophil count, and critically, the number and severity of extrahepatic organ failures: kidney, brain, circulation, lungs. They give a much more accurate prediction of 28-day and 90-day mortality for that specific, highly inflammatory ACLF patient profile.
Okay, so we've worked up the patient, identified the likely cause, and stratified their risk. Now the focus shifts immediately to management, and it sounds like supportive care is paramount.
It is absolutely the cornerstone. Supportive care is what keeps the patient alive while etiology-specific therapies might work, or while we're waiting for potential transplant evaluation, or even spontaneous recovery in some cases. It's non-negotiable.
Let's break down the key elements of supportive care. Fluid management sounds tricky.
It is nuanced. We need to maintain hemodynamic stability, support organ perfusion, especially for the kidneys, which are incredibly vulnerable in liver failure. So judicious IV fluids are necessary, but, and this is a critical warning, we must strictly avoid hypotonic solutions. Things like half-normal saline or D5W alone are generally out.
Why the strict avoidance of hypotonic fluids? What's the danger there?
The danger is cerebral edema. Patients with liver failure often have impaired free water clearance, partly due to high levels of antidiuretic hormone, ADH. This makes them prone to developing hyponatremia, low sodium levels. In the setting of impending or established ALF, hyponatremia significantly worsens astrocyte swelling in the brain, increasing the risk of cerebral edema and potentially fatal brain herniation. So it's a really tightrope walk. You need volume for the kidneys, but you absolutely have to maintain near normal serum sodium using isotonic fluids like normal saline or balanced crystalloids.
That makes sense. What about other metabolic issues, hypoglycemia?
Hypoglycemia is very common and dangerous because the failing liver can't perform gluconeogenesis effectively. It requires continuous glucose monitoring, often hourly in severe cases. We strongly recommend proactive management with continuous IV glucose infusions, often 10% dextrose, to provide calories and help maintain fluid tonicity, even prophylactically in high-risk patients. And alongside that, prompt identification and correction of electrolyte abnormalities, particularly potassium, magnesium, and phosphate, and any acid-base disturbances are mandatory.
Now, nutrition. There used to be a dogma about restricting protein in patients with hepatic encephalopathy. What's the current thinking?
That dogma has been largely refuted by current evidence. Protein restriction was thought to limit ammonia production, but we now know these patients are intensely hypercatabolic. Malnutrition worsens outcomes, impairs immune function, and potentially hinders liver regeneration. So current guidelines strongly recommend aggressive nutritional support, aiming for 1.0 to 1.5 grams of protein per kilogram of ideal body weight per day. Enteral nutrition feeding through a tube if they can't eat is preferred.
When would you temporarily reduce protein then?
We'd only consider a transient reduction in protein intake if the patient has rapidly worsening high-grade encephalopathy or clear clinical signs suggesting worsening intracranial hypertension, where ammonia might be a contributing factor. But the default, absolutely, should be aggressive protein provision.
Infection control seems like another huge priority, especially given the SIRS association.
It's critical. The combination of impaired immune cell function from liver failure, potential malnutrition, and the systemic inflammation itself puts these patients at an extremely high risk for both bacterial and fungal infections. These can be insidious, sometimes presenting without obvious fever. Therefore, a low threshold for suspicion is key. Early empiric broad-spectrum antibiotics are generally warranted if a patient presents with coagulopathy, any evidence of organ failure, like AKI or worsening encephalopathy or overt SIRS. Aggressive surveillance, like diagnostic paracentesis if there's a site ease, repeat blood cultures, urine cultures, chest x-rays must be routine.
Okay, last point on supportive care. Coagulopathy. IR is often very high. Why don't we routinely give fresh frozen plasma, FFP, to correct it?
This is a really important concept based on pathophysiology. While the INR is prolonged because the liver isn't making enough vitamin K-dependent clotting factors, 2,7-9X, it's also not making enough natural anticoagulants like protein C, protein S, and antithrombin. The net effect is often a state of rebalanced hemostasis despite the high INR. Giving FFP prophylactically can actually tip this balance towards a prothrombotic state, increasing the risk of clots, without clear benefit unless there's active bleeding.
So when do we give FFP or other factors?
We reserve correction primarily for situations of active, clinically significant bleeding, or immediately before performing necessary invasive procedures where bleeding risk is high, like placing a central line or performing a liver biopsy, or maybe even a large volume paracentesis. Routine correction, just based on the number, is not recommended.
That's a crucial takeaway. Okay, let's move into the etiology-directed pharmacologic management, starting with severe alcohol-associated hepatitis. Corticosteroids are first line.
They remain the first-line therapy, yes. Specifically for patients meeting criteria for severe AH, typically that Maddrey score of 32 or higher, or a MELD score over 20. The usual regimen is prednisolone, 40 milligrams daily, typically for 28 days.
But not everyone gets them.
Correct. There's a significant list of contraindications that must be screened for. Active infection is an absolute contraindication. You can't give steroids if they have ongoing sepsis or pneumonia. Uncontrolled gastrointestinal bleeding is another. Significant renal failure, usually defined as creatinine above a certain threshold, like 2.5 milli-GDL, is often considered a contraindication too, although that's sometimes debated. The potential benefit has to be weighed against these risks, particularly the risk of infection. And that brings us back to the day 7 assessment.
Right, the Lille score. So if the Lille score at day 7 shows non-response, we stop the steroids. Is there any wiggle room there? What if they're borderline?
Clinical judgment always plays a role, of course, but the Lille score carries substantial weight precisely because of that infection risk. If someone is a clear non-responder, the data strongly support stopping. If they're borderline, you'd look closely at the overall clinical picture. Are they developing signs of infection? Is their renal function worsening? Is the SIRS persisting? Often these factors will push you towards discontinuation, even in borderline cases. The consensus is quite strong. Continuing steroids beyond day 7 without a clear biochemical response, mainly that drop in bilirubin, likely causes more harm than good.
What about other drugs sometimes mentioned for AH, things like N-acetylcysteine, NACCSF, pentoxifylline, or metadoxin?
Yeah, there's been research into various adjunctive therapies targeting different aspects of AH pathogenesis, oxidative stress, inflammation, neutrophil function, endotoxin levels. NAC has probably shown the most promise in some studies, potentially reducing short-term mortality, maybe particularly when given with steroids. However, the overall evidence base for these agents remains, I'd say, low to moderate certainty at best. Pentoxifylline, for example, was studied quite a bit, but ultimately large trials didn't show a clear benefit. As of now, major society guidelines from ASLD and ESLO do not recommend any of these NAC GCSF pentoxifylline as standard of care treatment for severe AH outside of clinical trials. Corticosteroids remain the only pharmacologic therapy with established, albeit modest, benefit in responders.
Okay, let's turn to acute viral hepatitis B. You said most cases resolve spontaneously. When do we actually use antiviral therapy?
Antivirals are really reserved for the severe end of the spectrum. If an acute HBV infection progresses to fulminant hepatic failure, ALF, meaning they develop encephalopathy and severe coagulopathy, then initiating antiviral therapy is generally recommended. Also, if the presentation is actually an acute exacerbation or flare of underlying chronic HBV, what we might call HBV-related ACLF, especially with a high viral load, HBV DNA, and significant liver decompensation, then antivirals are indicated.
Which antivirals do we use?
We use the potent high barrier to resistance nucleose T-tide analogs, primarily entecavir or tenofovir, either TDF or TAF.
But you mentioned earlier the evidence here is somewhat controversial. Why is that?
The controversy really stems from the quality of evidence, particularly in the de novo acute HBV setting leading to ALF. It's often difficult to prove definitively that the antiviral therapy itself is changing the course of the ALF, which is often driven more by the host's massive immune response to the virus rather than direct viral cytotoxicity at that late stage. Some argue the patient might have spontaneously cleared the virus anyway, or that the outcome is determined before the antiviral could have a major impact. The stronger rationale is perhaps in ACLF flares, or to prevent progression to chronic infection, and certainly to reduce viral load if the patient is heading toward liver transplantation. But it's definitely an area where the evidence isn't as robust as we'd like. Treatment is also typically long-term once started.
Understood. What about the other common viral causes, hepatitis A, E, and C?
For acute hepatitis A and acute hepatitis E, management is almost entirely supportive care. There are no specific antivirals for them. The body usually clears these infections on its own, although HEV can become chronic in immunocompromised hosts. For acute hepatitis C, management is also primarily supportive initially. However, with the advent of highly effective direct-acting antivirals, DAAs, there's a consideration now for treating acute HCV, especially if the presentation is severe or if the patient is at high risk of progressing to chronic infection. The optimal timing and specific criteria are still evolving, but it's an option in select cases, unlike in the past.
And acute hepatitis D.
Sadly, for acute HDV co-infection or superinfection, we still lack effective therapy that directly targets the hepatitis D virus itself in the acute setting. The only strategy we currently have is to treat the underlying hepatitis B virus with entecavir or tenofovir, as HDV relies on HBV for its life cycle. Suppressing HBV is the indirect approach.
Okay, let's cover DILI, drug-induced liver injury. Step 1 is obviously stopping the suspected offending agent. What about N-acetylcysteine, NAC? We know it's vital for acetaminophen overdose. Does it have a role beyond that?
Yes. So for acetaminophen overdose, NAC is absolutely critical. The intravenous protocol is standard. The earlier it's given, the better the outcome, ideally within 8 hours of ingestion. But there's benefit even when given later, particularly if liver injury is already established. Don't delay administration while waiting for levels if suspicion is high. Beyond acetaminophen, the role of NAC is more debated, but there is some evidence. Studies, particularly one large NIH trial, suggested a potential benefit for NAC in patients with non-acetaminophen-induced ALF, but specifically in those presenting with early stage, grade 1 or 2, hepatic encephalopathy.
How might it work in non-acetaminophen cases?
The proposed mechanisms are related to its antioxidant properties, improving microcirculatory blood flow, and potentially replenishing glutathione stores, which might be depleted in other forms of severe liver injury too. It's not considered standard of care for all DILI or all ALF, but it's something often considered as a potential supportive or bridging therapy in unexplained ALF, especially with that early encephalopathy.
This naturally leads us to the highest level of acuity, managing established acute liver failure. This clearly requires an ICU setting and a multidisciplinary team.
Absolutely. Once ALF is established, it's critical care management, pure and simple. The #1 priority becomes airway protection and neuroprotection.
Why airway first?
Because hepatic encephalopathy progresses rapidly. Patients with grade 3rd, stuporous but arousable, or grade 4th, coma encephalopathy, or even those with significant agitation, grade 2, that compromises their safety or neurological monitoring, generally require prompt endotracheal intubation and mechanical ventilation. This prevents aspiration pneumonia, which is common, and allows for controlled sedation, which is itself neuroprotective, by reducing cerebral metabolic demand.
And you mentioned neuroprotection is key. Cerebral edema is the big killer here.
It remains the leading cause of death in ALF. The mechanism is complex. Hyperammonemia leads to astrocyte swelling. There's breakdown of the blood-brain barrier due to inflammation, and impaired cerebral blood flow autoregulation. All this culminates in increased intracranial pressure, ICP, and the risk of brain herniation.
So what are the core neuroprotective strategies?
Several key things. Maintaining the head of the bed elevated, usually around 20 to 30 degrees, helps promote venous outflow from the brain. Avoiding any maneuvers that could increase intra-abdominal or intrathoracic pressure is important. Strict avoidance of hypotonic fluids, as we discussed, is crucial to prevent worsening cerebral edema. And close neurological monitoring, looking for any signs of rising ICP.
What do we do if we suspect ICP is rising, even without invasive monitoring, which isn't always available?
If you see clinical signs concerning for elevated ICP, like new hypertension, bradycardia, changes in pupillary response, or posturing, you have to act quickly. The first-line treatments are osmotic agents. Mannitol, given as a bolus, or infusions of hypertonic saline, typically 3% saline, are used to draw water out of the brain tissue and reduce swelling rapidly. Continuous vigilance and a low threshold for these interventions are necessary.
Let's talk organ support. Kidney failure, AKI, is common. You mentioned continuous renal replacement therapy, CRRT, is preferred over standard hemodialysis.
Yes, CRRT is generally the standard of care for renal support in ALF. The main reason is its much gentler hemodynamic profile. These patients are often vasoplegic and hypotensive, and the large fluid shifts associated with intermittent hemodialysis can worsen instability. Perhaps even more importantly, CRRT provides slow, continuous removal of waste products, including ammonia. It's much more effective at controlling severe hyperammonemia than intermittent dialysis, and it avoids the rapid osmotic shifts that could potentially exacerbate cerebral edema during standard dialysis.
And throughout all this critical care, the possibility of liver transplantation looms large.
It has to. Given the dismal spontaneous survival rate for irreversible ALF, often quoted around 25% or even lower depending on the cause and severity, liver transplantation offers the only realistic chance for long-term survival for many of these patients. Therefore, early consultation with the transplant center and formal evaluation for listing are absolutely mandatory as soon as ALF is recognized or strongly suspected. Using prognostic criteria like the King's College criteria or MELD score helps triage, but the process needs to start immediately. Missing that window is a critical failure.
Are there any therapies used specifically as a bridge to transplant while the patient is waiting or being stabilized?
Yes. High-volume plasma exchange, HVPE, has gained traction as a potential bridge therapy. The idea is to remove large volumes of the patient's plasma, which is laden with toxins like ammonia, bilirubin, inflammatory cytokines, and possibly other harmful mediators, and replace it with fresh plasma or albumin solution. Studies suggest HVPE can temporarily improve organ function, particularly neurological status, and sometimes renal function, and may stabilize hemodynamics. It's thought to essentially clean the blood, buying time for transplants, or, in some rare cases, perhaps even allowing the native liver a chance to recover. It's an intensive therapy, but can be life-saving in select candidates awaiting transplant.
Okay, moving towards wrapping up our discussion.
Right.
Let's reemphasize a point made earlier. It's often the complications, rather than the initial liver injury itself, that drive mortality.
That's absolutely correct. The complications are relentless and often synergistic. We've talked a lot about hepatic encephalopathy progressing to cerebral edema that's swift and often irreversible once severe herniation occurs. It requires hyper-proactive management.
And infections.
Infections and sepsis are probably the most common immediate threats, especially in the context of severe AH with SIRS, but also in any ALF patient due to their immunocompromised state. Bacterial infections, pneumonia, spontaneous bacterial peritonitis in those with ascites, line infections, UTIs, and increasingly, fungal infections are alarmingly frequent. These infections rapidly trigger or worsen multi-organ failure. Early detection and aggressive treatment are paramount.
We also touched on acute kidney injury. How common is that?
AKI is incredibly common, occurring in up to a third or even more of patients with severe AH, and frequently complicating ALF from any cause. Its development is a major independent predictor of mortality. Whether it starts as prerenal isotemia due to dehydration or vasodilation, or progresses to the specific entity of hepatorenal syndrome, kidney failure dramatically worsens the prognosis.
And cardiovascular issues.
Cardiovascular collapse is also frequent. The systemic inflammation and release of vasodilatory mediators lead to a low systemic vascular resistance state, causing hypotension that often becomes refractory to fluids alone, necessitating vasopressor support, like norepinephrine, to maintain vital organ perfusion. Eventually, this can progress to irreversible shock.
So summing that up, the managing team really has to view these patients not just as having liver failure, but as being in or rapidly approaching multi-organ failure.
Precisely. It demands that holistic, anticipatory, critical care approach. You have to constantly look ahead, anticipating the next likely complication across every organ system: neuro, renal, cardiovascular, infectious disease, metabolic. That's why the mortality rates remain so high. 90-day mortality for severe AH can range from 20% up to 50% or more in some series. It requires aggressive, proactive management and immediate collaboration between hospitalists, gastroenterologists, hepatologists, critical care specialists, and transplant teams.
Okay, this has been an incredibly detailed discussion. To close this deep dive, let's try to synthesize the key takeaways. The hierarchy of care for managing acute hepatitis in the hospital.
Sure. I think number one, absolutely foundational, is meticulous supportive care. Managing hemodynamics and fluids carefully, ensuring adequate nutrition, preventing hypoglycemia, protecting the airway early if encephalopathy develops, and vigilant infection surveillance and control. That's the bedrock.
Right, supportive care first.
Second is precise and, importantly, dynamic risk stratification. Use the validated scoring systems MELD and Maddrey initially, especially for AH, to gauge severity. And then, critically, use the Lille score at day 7 in AH patients receiving steroids to guide the decision on continuing therapy. For ACLF, remember the specific ACLF scores are better predictors. This stratification dictates monitoring intensity and therapeutic choices.
Okay, supportive care, then risk stratification. And
Third is the etiology-specific therapy applied judiciously based on that risk stratification. This primarily means corticosteroids for severe, non-infected AH patients identified as likely responders by day 7. For viral hepatitis, it means antivirals only in carefully selected cases, primarily severe or fulminant HBV, or possibly acute HCV in certain situations. And of course, immediate NAC for acetaminophen toxicity and withdrawal of the offending agent in any DILI.
And we should probably acknowledge the evidence base we're working with.
Yes, it's important to remember that while we follow consensus guidelines from major societies like ACG, AGA, ASLD, SCCM, many of the recommendations, especially regarding antiviral use in acute viral hepatitis or some adjunctive therapies, are based on evidence that's often graded as low quality or comes from studies with limitations. There's still a significant reliance on expert opinion and clinical experience in some areas.
That's a crucial caveat. It highlights areas where more research is needed.
Definitely. The management of acute liver injury and failure is evolving, but studying these critically ill, heterogeneous populations in large randomized trials is incredibly challenging.
So this leaves us with a really interesting, maybe provocative thought for our listeners, fellow clinicians, and researchers. We've made huge strides in supportive care in the ICU, things like better renal replacement therapies like CRRT, understanding fluid management, advances in plasma exchange, sophisticated ventilation and neuromonitoring. Yet, despite all that, mortality remains stubbornly high once a patient develops irreversible ALF or severe ACLF. And we still lack truly curative pharmacological options for many key causes, like severe AH or acute HBV that progresses rapidly.
Exactly. So the provocative question becomes one of resource allocation and research focus. Given the high mortality and the reliance on transplantation for irreversible cases, where should the bulk of our efforts and funding go? Should we prioritize refining liver support systems, better artificial or bioartificial liver devices primarily as an advanced bridge to transplant, keeping patients alive longer while they await a donor organ? Or should the main push be towards discovering and validating novel anti-inflammatory, anti-fibrotic, or regenerative therapies that could actually induce spontaneous recovery of the patient's own liver, even in high-risk situations, potentially avoiding the need for transplantation altogether?
Bridging versus regeneration. It's a fundamental question about whether we focus primarily on replacing the failed organ or finding ways to salvage it. Something important for all of us involved in caring for these patients to consider.